In this presentation, I will take a more clinical angle to the question of diagnostics and how we are deploying them now. So these are some of the questions we'll look at during this presentation. What are the current novel POC diagnostics? What are the role of RDTs or rapid diagnostic tests in COVID-19? What are optimal samples? Can testing evaluate infectiousness, and what the appropriate immunologic correlates, and what progress have we made in this area for the protection, what's considered protective against COVID-19. So this slide basically, is what we might face in a typical day when we are either running the inpatient ward or we are running a clinic in our special precautions area where we evaluate COVID suspects or COVID confirmed patients. So there are 4 patients here. First, we have a 40-year-old male who has cough and fever for 2 days. His wife was diagnosed with COVID 3 days ago. His rapid antigen test is positive. You request a PCR and it's pending. The second patient is a 30-year-old female nurse who's asymptomatic. She has no known COVID contacts. We have started something called rostered regular testing or routine testing, where we are all mandated to do twice a week rapid tests to screen for COVID, and hers was positive. And because she was very worried, she repeated it 3 times in the same day and it was positive, and she's here for evaluation. You do a PCR and the PCR is negative. So what do you do? The third patient is admitted inpatient for asthma exacerbation, has no known COVID contacts, did not get a rapid test antigen result, but the first PCR was detected. That PCR you used had looked at 2 genes, and the CT values you can see were around 28 for both targets. And then you repeat them, one on the same day, one on the next day, and not detected. What do you do? And patient 4 admitted for fever and cough 7 days ago, found to have pneumonia in the peripheral area, looking very in the bases of the lungs, looking very suspicious for COVID. And the colleague in the office was diagnosed with COVID-19. The PCR swab, you did it 3 times in the NP swab and it was not detected. What do you do? So these are really common scenarios that our clinicians would face. Now, in terms, we'll get back to those scenarios and we'll try to kind of answer them. But current and novel diagnostics of COVID-19, I think there are 4 main methods: tests which detect nucleic acid, tests which detect viral antigens, tests which then detect the antibody response, and then other novel methods which we won't speak so much about, but people have looked at mass spectrometry to look at the protein and charge signals. They have looked at volatile organic compounds which host signatures which might occur when we are infected with various pathogens, but those are still works in progress and there have been technical challenges. So biosensors are still an area of active research. However, nucleic acid amplification tests are the workhorse, and I think we are all familiar with PCR. Which is one of the nucleic acid amplification tests. I think coming onto the scene more so in the 1990s to the 2000s, and being a lot of earlier work in translating it from research and use in clinical labs in the early on in the 80s. Now PCR, of course, is a very common thing in most diagnostic labs. Now, as of November 2021, there have been 66 provisionally authorized PCR tests by the HSA in Singapore. If you look at the FDA EUA clearance list, there are 269 molecular diagnostic tests now on the FDA website for SARS-CoV-2. PCR, of course, is versatile. There's long-term experience. You can have, there's quick setup speed. And in fact, in Singapore, when we first before the assays were set up specifically for SARS-CoV-2 with the published sequences, and actually our National Public Health Lab had been preparing for a coronavirus outbreak. They had a pan-coronavirus PCR, which we used initially to diagnose our first cases of COVID, and after that, sequencing. Now, PCR is the method of choice for or NAT test for confirming SARS-CoV-2 infection, but I think we must remember there were supply chain issues at the height of the pandemic. Now, innovations in NAT tests tests over the last decade include simple near-patient point-of-care formats, higher throughput solutions, improvements to pre-analytics, and also isothermal approaches like loop-mediated isothermal amplification or LAMP testing. Now, there's also been a move towards direct sample processing, removing the extraction step, but of course, we need to be a bit wary for extraction-free steps because sometimes that might reduce analytical sensitivity because extraction increases the target and reduces possible sample-derived inhibitors. But having said that, though, there have been some products which have been quite successful with extraction-free or on-instrument extraction approach. I think this slide just shows some data, and I think it was an issue that also confronted us during the pandemic, that lab supplies were an issue during the pandemic. This is a snapshot from the American Society of Microbiology on their listserv. I think they collate feedback from all the labs about shortages that they experienced during the pandemic, and you can see that there were problems with extraction kits, consumables, also LDT control materials, some issues with the PCR or the NET test kits themselves. And in the lower part of the chart, you also see that while testing was impacted, actually the other areas in the regular diagnostic lab were also affected. Bacteriology, mycology, microbacteriology, and the parasitology labs also faced shortages. So I think this is a lesson that we learn, that not only is the specific test kit for COVID important, but lab supply certainly can be an issue in a pandemic. And in planning for one, we need to take note of the entire chain of testing. I think during the pandemic, it also drove innovation. I mean, various labs looked at alternatives when UTM was short, alternatives to viral transport media. So this is one study from the Mayo Clinic, which looked at just using swabs in saline as an alternative to viral transport media. Some labs in Singapore, for example, SGH lab, uses actually dry swabs. So these are some of the ways where labs had to really validate and verify their processes to kind of get around and also improve testing turnaround despite the challenges faced. And of course, there were also other homegrown kits, like here, the Fortitude kit, which was covered on in another talk, which was co-developed by in Singapore by folks at Tan Tock Seng and also A-Star. And then this other kit called the Resolute kit from the DSO, which is an extraction-free kit, so direct from specimen RT-PCR. So having said that, if you look online, there are many rapid molecular tests, and we won't go through all of them, but you can see what does rapid really mean. And I think different people would have different ideas for in the world of mycobacteria. I guess 6 to 8 weeks to culture out anything that's maybe relatively slower, and people get impatient. But for rapid testing, I think most people generally take that the test should be in a clinically relevant period of time where the patient is kind of waiting for a result. Most patients are quite wouldn't want to be in the doctor's office for more than an hour or two. So the test should be able to deliver clinically meaningful results within an hour or so. And here we can see that there are multiple tests. Some of them, the chemistry is a bit different. Some use LAMP, some use PCR, and most of them deliver a result between 13 to 30 minutes here. I think if you look carefully, it's important while the test results come out quick, there are indeed, even on this slide, there are tests with varying sensitivities. For example, the Abbott kit, I think when it was rolled out subsequently, the sensitivity was not as high as expected. It was in the 80s. But there are others which still need to be used in a lab setting. because they are complex tests, but some, for example, the Lucira Health test and some other systems like the LIAT test, which can be used actually at almost at point of care. So here we move on to talk about rapid antigen tests too. So I think there have been advocates and people who are not so for rapid antigen tests. I think this has evolved in the whole pandemic. And while we had a very strong emphasis on the need for PCR confirmation in this phase where we have started moving on in many parts of the world, and especially, for example, like in Singapore, where we may not be able to get to test everyone on a PCR or in a timely fashion, then rapid antigen tests are a good way to consider because they are less expensive. The results are ready usually within 15 to 30 minutes, and they can be deployed very easy for it to be performed by healthcare workers or patients themselves. The diminished sensitivity always has been kind of like a bugbear, but actually the kits which have come out have a decent sensitivity, I think, usually in the 70s to 80%, depending on the phase of the illness. But because they are more rapidly deployable, they have a faster turnaround time, and they may catch people with lower CT values or higher viral loads during the clinically relevant period for infectiousness. So at least in many jurisdictions and parts of the world, these have kind of form part of the screening armamentarium. This is a study of the UK which looked at, while it was done on frozen swabs, which is a limitation of 1,400 individuals. And it was just a nice study to just show that when the performance of rapid antigen tests vary according to the disease status and also the reason you're using it and also the viral load. So sensitivity in this study was highest when the CT values were below 25, it was 98%, and then you look at cutoff of less than 30, it was about 95%, and it was higher sensitivity when you were testing cases and controls rather than asymptomatic screening. In another study where they looked at over 2,000 samples, and this was looking at the standard Q COVID antigen test. Again, from a study in Germany, you can see that, again, there's a correlation between lower CT values and higher sensitivity. And as you go above like 30 and 35 here, then you can see the sensitivity drops off. We have been involved in NCID looking at various operational evals. We don't do a full evaluation, but every time a test kit comes on the market, the ministry asks us to assist to do a little mini evaluation to verify the manufacturer's claims. And so sometimes, and not all rapid antigen test kits are meant for self-testing. So some of them are meant to be deployed by used by healthcare workers testing the patient rather than self-testing. So these are some of the kits we looked at for self-testing, and we do ask the patients questions whether they understand instructions, how easy was it to self-test, what the patients themselves preferred, and so here are some of the results. And recently we looked at one of a LAMP test, which was rather interesting. So this is a very limited operational evaluation. So we looked at about 60 patients, 30 positives, 30 negatives, and you can see that here, it's interesting that this LAMP test detected and compared to PCR, and we used the gene expert. So when compared to gene expert, actually it detected all the patients, even from a range of CT values that we studied from 12 to 36, and this is now an FDA approved test at home, and it comes in a neat little one-use package here. So if you look at the rapid antigen test, I think there's a plethora out there. But of course, not all perform exactly the same. There are those that have slightly higher sensitivity, but most of them have had quite a decent specificity actually, and false positives are not as common with the rapid tests which have been approved on the market. But again, whether it is with PCR or RDTs, prevalence and pretest probability matters. So I think this colored diagram here in this paper actually illustrates this principle quite well. If you have 5% prevalence and a population of 400 people have been tested, then and you can see that an individual who tests positive has the positive predictive value is about 50% of being infected. Of course, if the prevalence goes up to 25%, as in scenario C, then the PPV goes up to 86%. So a lot of the test accuracy results also depend on the prevalence and the pretest probability of the population you test. And of course, as the outbreak went along, we also learned, and we didn't know this, but of course, soft drinks are very acidic, and I guess they mess up the pH and biochemistry of the lateral test kits. So I think some people might have, some groups might have use of having a false positive. So kids were using it at one point to get false positive results to get out of school. Hopefully that's not a huge problem where you work, or now it's in the school holidays, that shouldn't happen. But so false positives, in essence, can happen, whether it is with PCRs or RDTs. Now, the stage of illness and sample site also matters. So here you see a diagram where the viral RNA peaks and then comes down. Certainly after the first week of illness, it drops, and then the serologic response occurs. And we did a study in NCID a bit early on in the outbreak where we looked at a bunch of slightly over 100 patients, and we found that the nasopharyngeal specimen as an anatomic site had the highest clinical sensitivity at 85%, followed by throat at 80%, the mid-turbinate swab here in our study 62%. This is overall. And saliva, here our saliva was not, there have been other studies which found good performance of saliva, but this was drooled saliva in this study, and it just went up as high as only about 50%. In the first week of illness, to less than 7 days, the sensitivity of the NP nasopharyngeal swab was 95%, and then 88% for throat, 72% for mid-turbinate. When you got pneumonia, then the sensitivity actually does drop. When pneumonia, it usually occurs in the second week of illness, and then even for the NP swab, the sensitivity falls down to 70%. So I think that was really quite instructive for us, that patients, depending on their phase of illness, and sometimes they don't give a very good history. When you have a patient with pneumonia coming into you, then the sensitivity of testing might be already a bit lower. So back to our case vignettes. Here in case 1, this is likely a true positive because the pretest probability is high and this PCR was positive. The second one, and we have seen this, quite a curious case. I was called one day about a case exactly like this, and interestingly, we did PCR as negative, and I think with a separate antigen test kit, it was actually a negative test. So some people might have some biologic factors leading to either in their secretions or something which leads to a positive, false positive result with antigen, a particular brand of antigen test kit. And here in scenario 3, this turned out to be a false positive, and that can happen for a variety of reasons, either sometimes pre-analytic reasons like specimen mix-up or splashes or cross-contamination. And then 4 is actually a so-called false negative PCR test. It's just that the biologic behavior of the virus such that deeper sampling might be needed, or repeat testing, or alternate samples, or even serology to help you. So here, this is a study out of New York, and it just looked at repeat testing and how many tests do we need to kind of look at to confirm SARS-CoV. So here in about 3,400 patients who had in a GP network who were tested and had repeat testing, 802 had initial positive results, 2,400 had initial negative, but then the negative predictive value, these are people who got repeat positives, was about 80%. And you can see if you kept retesting them, this is like the decay curve of the number of remaining negatives, a large number, that's a significant proportion needed a second test to then find out that they actually had COVID. So in our institution, we looked at this too, and this was a nice study by my colleague, Dr. Lee Tao Hong and Ray Lin. We found that about for people who were finally diagnosed with SARS-CoV-2 at an earlier time in the pandemic, about 88% had the first swab detecting COVID, and then later on, another 7% needed a second swab. So, and then the rest needed 3 or more, and of course there will be biologic outliers. So here in our institution and in most places, we do, if the clinical probability is high, the pretest probability, doing at least 2 swabs is still what we are practicing in our institution. So can testing help determine infectiousness? And this is another thing that often is asked. Viral culture, it is the gold standard, but it lacks sensitivity. There's a long turnaround time, and it's the only way to really determine replication competent virus. Rapid antigen tests, but then again, it's not so sensitive, so a negative culture can't really rule out ongoing infection. People have proposed using rapid antigen tests because they detect people with lower CTs and likely during the more infectious phase where you have viral proteins. But the sensitivity has been variable with kids, and sometimes false negative results might be possible due to viral mutations. And there are reports of course, antigen negative but culture positive cases. So again, not perfect. And then subgenomic RNA, which I didn't put on the slide, is another way, but that one also, in some studies, people have found that it lasts almost as long as, or maybe slightly shorter than viral RNA. And there's some question too as to whether it really predicts infectivity. And also then people try to use PCR itself with its CT values. Of course, the CT value was never meant to be a kind of unit of measurement. And there are studies seeming to indicate, and I will show you some data from our institution, that the CT value of more than 24 or 30 and more than 8 days from illness less likely to culture virus. But then again, there are many pre, intra, and post-analytic variables affecting CT values. So having said that, we did look at this in NCID, and you can see this is pre-Delta. We found that about 68% of patients with wild-type virus would be PCR negative by day 21. Of course, PCR negativity does not, you might detect it to be high CT values, but they may not be infectious. And our data kind of corroborated with other data which came out of early on in the pandemic out of Hong Kong U, where they found that the infective period's most likely between day -2 and kind of tails down by day 8. We were not able in our NCID cohort to culture virus when CT values were more than 30. And this was a study which was published by my colleague, Dr. Barney Young, and you can see in the red dots, and from days of symptom of onset, they all tended to be in the lower CT values below day 30 in the pre-Delta period, and also around before day 15. When we looked at it during the Delta period, I think Prof showed some similar, a similar slide where we had looking at vaccine breakthrough cases. Here we found that in fully vaccinated people, they tended to in fitted curves, decrease in shedding by day 9 compared to day 15 in non-vaccinated patients. And this again broken down for the symptomatic cases about day 10 versus day 16. So quite similar whether you're asymptomatic or not during the Delta period. And then we tried to culture a subset of like 20 samples during NCID during the Delta variant period. And you can see that in the line, sorry, the slide is a bit small, but below a value above CT25, we were not able to culture viable virus. And this was data which our NPHL lab together with Duke, NUS, and US kindly provided. And then most of them also had higher levels of CPAS, which is a neutralizing antibody titer for the CPAS assay. More than 30% is taken to be a decent neutralizing antibody levels, and we weren't able, those who did not have viable virus tended to have higher CPAS levels. Here for de-isolation here in Singapore, then we have taken based on the data, kind of in the UK, they take about 14 days for de-isolation, 10 days in the US. We have kind of gone to differentiate it between whether one is vaccinated or not. But of course, if if the patient is recovered, then taking a CT value of more than 25 to 30, if you are planning to de-isolate your patient before that, we do use locally PCR to guide us. If they're immunocompromised, of course, then all bets are off, and so we might sometimes use testing to guide us. And generally, locally, we recommend 21 days of isolation at least, or self-isolation at home. Here, this is the last case. This is a patient who had breakthrough viral infection, and the S antibody is 125 by the Roche assay. His CPAS is 35, and he has COVID pneumonia. What do you think? He asked you, is that a sufficient antibody response? Yes, you do have antibodies, but it's not high, protective enough. Yes, you do, and it's sufficient. No, you have a negligible. Or number 4, I don't know. We don't have an internationally recognized protective correlate. So I think more, if we were to really poll the audience, it might be a scattering of answers, and really, truly, we don't really know. And immune correlates against COVID-19 are still needed. What is important to know is that I think here, at least in one study for the Roche assay, people with poor vaccine response seem to have low below 100, and then if you had 2 doses of the Pfizer vaccine, it went up to about 3,000. But I think there are movements in the right direction. The WHO now has an international standard, and this was adopted in late December 10, and I think this is going to start to form the language for common reporting. And I think over here is just showing the various immune markers that folks have studied and their half-life. And I think antibody correlates. I just point you to a study here that detectable SARS-CoV-2 infection in this study by Curry et al. That the neutralization level in this that they put together was that for protection either against detectable SARS-CoV-2 infection, we needed it to be about 20% of the mean convalescent levels of the standard. For severe infection, actually it went to pretty low. You needed 3% of the convalescent level from the standard, which they use. And this study, they had pulled together various studies and normalized it to the mean convalescent titer. So I'll point you to this study if you for further information. So what we didn't discuss, there are many other things that we didn't talk about. Singleplex, multiplex, how do we look at reinfection? Should we be even testing people in the endemic phase? Wastewater testing, the role of the routine diagnostic clinical lab and variant detection. Would resistance happen? And just as we speak now, there's the first report of remdesivir resistance, which was reported by Yale. And this was a patient who had B-cell lymphoma and had infection which recrudesced after about 140 days of infection. She had received rituximab, and they were a bit suspicious because she had worsened pneumonia, and they cultured the virus and they sequenced, and they found a mutation with whole genome sequencing E802D in the non-structural protein 12 region. And I think here, as we start using more therapeutics and people with immunocompromise and even recurrent infections or recrudescence, this is something that we need to watch out for. So I would just like to end here and just thank my colleagues at NCID, especially the clinical ID department, nursing, our pharmacy, social workers who have been taking care of patients, and our public health officers, IDRTO, the ID Research Lab, the National Public Health Lab, and MPHEU, which generated a lot of the data I showed, the MOH, and collaborators in the various institutions and the public hospitals in Singapore, our colleagues in Tan Tock Seng DLM, Duke, NUS, and also to the patients for whom we care for and their families, for which a lot of this data was based on. Thank you.